Welcome to the Dr. Mudgil podcast. This is episode 175. We are just about wrapping up March here. Time is just flying by. Spring is officially here, which is nice. We're getting a little taste of spring, I think, this week, and we're going to actually have like an 80-degree day here in the New York area, which I'm very excited about. So with that, let's move on to the content of this podcast. So this past week, I think it was this week, or maybe it was I think it was last week actually. It was match day for residents. So when you're in medical school, you apply for residency, whatever field it is that you're going into, like dermatology, internal medicine, pediatrics, and then you find out on one particular day. You find out on a Monday if you matched, and on a Thursday you find out where it is that you matched. So there's all these young, hopeful, doctors I was seeing, or future doctors, about to graduate medical school. I saw the enthusiasm in their eyes, and it wasn't that long. I mean, it was a very long time ago when I had match day, but it doesn't seem like it was that long ago. And it really had me thinking a bit about being a doctor. And one of the things I've actually been thinking about quite a bit is the art of medicine, becoming a doctor and actually practicing medicine. Because, when you come out of medical school, you really have no idea how to be a doctor. I remember when I was an intern and just really having to lean on the nurses, who are like a huge resource for interns, because, they've been around the block and seen basically everything. And they would kind of say, hey, doc, do you think you want to order this medication? And you're like, yeah, that's right. That's what I do. That's a good idea. And you learn really quick that, the nurses are your biggest advocate and your best friends. So I never understood why interns and young doctors would not be nice to the nurses, because that was always a very, very foolish decision, I thought. Without the nurses, I wouldn't be where I am today. So thank you, you wonderful nurses out there. And thank you for saving my ass many times during my internship year. But it's interesting that, the more you practice medicine, so you realize internship year that, oh my God, I just graduated medical school, but I really don't know anything about taking care of patients. You have all this knowledge and you think you kind of know, but you've never been the person on the hook to make decisions for patients. And you learn really fast as an intern. You learn really, really fast. And, by the end of internship year, I was very confident. I learned a whole bunch. I knew how to manage a whole bunch of different things in the hospital. And it's a very empowering feeling. And then for me, I did 1 year of internal medicine, and then I started my dermatology residency. And then when I started my dermatology residency, I was like, oh my God, I know all these like little facts and figures and things, but I have no idea how to take care of a dermatology patient. Like, you're seeing like rashes for the first time that you've never seen, like skin cancers and, all of these like very complicated disease names that you've never heard of. It's like a completely different language. And like, oh my God, like how am I ever going to learn this stuff? And then, by the time you get to like the end of your residency, you're like, wow, I know all of this great stuff. And I've learned so much and I'm ready to be a dermatologist. And then you start practicing dermatology and you're like, wait a second. It was like so much easier being a resident when there was like a supervising doctor, kind of, you can, or a supervising resident, if you're a first year resident, like someone senior to you, that you could ask what to do and, can help you out. And you kind of like learn all over again at all of these stages, like different things you're learning. Now that I've been, at it for like 20-ish years or so, not quite, but almost there, I think a lot about like how I'm so much of a better doctor now than I was when I started practicing. And a lot of that is the art of medicine. And I'll give you a couple of examples. So this past week, I saw a patient, a teenage girl. I think she was like 15 or something like that. And she had cystic acne, hormonal cystic acne. So she kind of flared around the time of her period and also like when she ovulated. And, having done this for as long as I've done it, there's the typical approach that, I'd say like, the majority of dermatologists out there would use is, okay, the patient comes in, and you say, okay, why don't you try these couple of creams and this face wash and come back in like 4 to 6 weeks. We'll see how you're doing. And then patients come back with that regimen and they're kind of like, the same, maybe 5% better. And the next step would be like, hey, okay, why don't we try some oral antibiotics and like these creams, or maybe change your creams around, come back in like 6 weeks or so, come back, same sort of boat. But there's a medication that I've used a ton of throughout my career called spironolactone for women who have hormonal cystic acne. And it's like magical. It works amazingly well. So as my career has kind of developed, I frequently go to that as my first choice. I explain all of the options to my patients, of course. But, this would be like my recommendation for us. A teenage girl has hormonal cystic acne. I'll say, these are the options, but this is what I would recommend. I recommend like, we try this cream, we'll do these face washes, and spironolactone, which is a systemic medication. And I'm not gonna get into the science of it, but the reason why I like it is because hormonal cystic acne is kind of like a deeper type of acne. It's not like superficial stuff. So creams don't really get to where the action is. So you kind of need an inside out type of treatment, namely something systemic to treat an inside out type of acne. So back to this patient. So I was going through my usual rigmarole. I mean, this is like, I probably see like 30 patients just like this every week, if not more than that. And I said, this is my recommendation. And I could see like a little bit of trepidation in the eyes of my patient's mom who was in the room. And, like sensing that, I basically asked her, I was like, does this plan sound, okay to you? And she basically conveyed that, hey, listen, I think it's great, but I don't know if I necessarily want to start there. And I totally get it. And I said to the mom, I was like, listen, I totally get where you're coming from. Why don't we start like with, just some creams and a face wash and that sort of stuff. I'll explain to you exactly how to use this stuff. And let's have you come back in 6 weeks. And like, if things aren't much better, we can revisit this plan, like this plan B. Or, it was my initial plan A, but for them, it's their plan B. And to see if maybe that's a better fit, once we've tried plan A, right? And the hope is that plan A works and we don't need to switch to plan B. But the reason why I'm bringing this up is, yes, it's the art of medicine, but it really had me thinking a lot about perspective and, perception and expectations and all that sort of stuff. And, I will have patients sometimes that come to me with just like a face full of cystic acne, but they're here to see me for like a rash or something. And they really don't care about their acne. Like that's not, it really has no significance for them in their life. They don't want to address it. It's not an issue. But like the rash is that they came in to see me for is what's really bothering them. And, or I have patients on the flip side of it who are like, in entertainment and have get like a one cystic pimple every couple of weeks. Nothing really super significant in terms of like, the spectrum of acne. But for that particular patient, it's really, really significant and it's debilitating and it keeps them off camera, or whatever the case may be. So for them, treating that what's, minor quote unquote acne is something that's very important to them. And the more I've been doing this, the more I realize is, like for me, I'm a dermatologist, right? So when I look at someone's skin, my goal is always perfection. What can I do to make the skin as perfect as possible? But for my patient, that might not be their goal. Their goal might be like, hey, this doesn't bother me. Like, I don't really want to deal with it. And, it really has no impact on my life. Or it's like, this, quote unquote, minor problem in my eyes has like a significant impact on their life. And as you've heard me say many times over, the most important part of any anti-aging skin regimen is using a proper sunscreen, namely one that's at least an SPF 30 and contains titanium or zinc or both. I couldn't be more excited to announce the launch of these two amazing Dr. Mudgil brand sunscreens. One is tinted, one is non-tinted, depending on what your preference is. I also have an amazing hydrating and moisturizing serum, which your skin is absolutely going to love. There's a link in the description below, which you can click to check out the products. You are going to love them as much as I do. The art of medicine is listening to, or part of the art of medicine, I will say, is listening to your patient and tailoring whatever regimen you prescribe for your patient, tailoring it to what they specifically want. I'll give you another example of this sort of thing. I had a patient who was a postal worker in downtown Manhattan, like during 9/11. And, he was exposed, he was actually working the day of 9/11. He was exposed to, all the chemicals and all the craziness that happened down there when the buildings collapsed. And, a lot of folks that were exposed to all of those hazardous chemicals are starting to develop like cancers many, many years later. And, and skin cancer is considered one of the cancers that folks who endured those harsh circumstances of 9/11 who were downtown during that time, it's one of the cancers that are monitored, by there's a bunch of like healthcare agencies that monitor folks who are around or at the site of 9/11 or helping out and that sort of thing. So this particular guy who's a mail carrier he came to see me, this was years ago, a couple of years ago. He came to see me and he had 3 suspicious lesions on his face, which I biopsied. And all 3 of them came back as something called basal cell carcinoma. And so typically for basal cell carcinomas on the face, we refer our patients for a specialized type of skin cancer surgery called Mohs surgery. So we sent him to the local doc here, who I referred to, who's amazing. And he had one of the cancers treated, but never went back for the other 2. And, we keep a log of our cancer patients who need treatment who we refer outside to make sure that, everything comes full circle and that they have in fact been treated. And when we realized he hadn't been treated, we called him, we sent him letters, we reached out to him, and we finally got in touch with him. And he said, listen, I had one treated, and I'm just not going back. I'm not going to treat the other two. He's like, I can't really see them on my face. I'm just not going to treat them. And my PA spoke to him, and I said, hey, just have him come in. And he came in, and this was maybe like about a month or a month and a half ago. He came in, really, really nice guy. And I talked to him. I said, hey, what happened? And he said, well, I had the Mohs surgery, and the doctor was great. Everything was fine. But it was just torture. Like Mohs surgery is like, especially if it's like a multi-stage Mohs surgery, it could be like a full day-long process. He's like, listen, I just never want to do that again. And in his mind, he thought, okay, I'm either going to get Mohs surgery or I'll just hope that the cancers, when we biopsied him, went away. And that was basically it. But I mentioned to him, hey, I get it. If you don't want to do that, that's totally fine. There's other options. Like, we can have like radiation therapy for the skin cancers that are remaining. It's like very, very effective. Like typically we reserve that for folks who are not as healthy as you are. But you're certainly a candidate. If you want to have these treated surgically, I can refer you to a radiation oncologist and they can consult with you. And that might be a perfectly prudent way for you to manage these. And he was so relieved, and we set him up and he saw the doctors. And I think he's getting treated at present. But the point is, had we not communicated with my patient, kind of figure out, hey, what exactly is going on here? And what is your trepidation with getting these skin cancers treated? We never would have been able to tailor the approach that we had to, help our patient stay healthy. So the reason why I'm talking about the art of medicine is, unfortunately, the art of medicine is getting lost in this day and age. When you have an independent practice, like my practice, or your local family doc, or someone who's in private practice, you really get to know your patients. Like, your patients so well, them over the course of, many years, their parents, their kids, their grandkids, and you're taking care of people in a community. But since Obamacare, the Affordable Care Act, there's been a lot of quote unquote vertical integration in medicine, where basically like sprawling hospital systems are like usurping doctors' offices, and private equity is getting very involved in medicine. And then of course there's the private health insurers and the pharmacy benefit managers, like the four evil forces that I always mention, who are on the other side of the patient care fence, that are meddling with patient care. And small mom and pop shops like Mudgil Dermatology are really, going extinct. And, there've been all of these articles that have come out that, they thought this verticalization or the vertical integration of medicine was going to be like cut down costs and improve patient outcomes, when in fact it's the exact opposite. When there's consolidation in healthcare and like the local, small business doctor, the community doc is kind of run out of business, who suffers? Patients suffer. Healthcare costs go up. We all suffer. There's nothing more pure than the doctor-patient relationship. Patients come to a doctor because they need help. Doctors give up the entire decade of their 20s and more to pursue their passion, which is, learning how to be a doctor so you can take care of your patients. And then there's also, all of that learning that you do after you're a doctor. It's all about like learning the art of medicine so that you can take care of patients. When medicine gets vertically integrated, there's no relationship anymore with your patients. You're just the doctors are like a cog in this major bureaucratic wheel. You may not see your same doctor every time, and everything is done to like maximize reimbursements. And there's some like person in the billing office or someone with an MBA or some administrator that's telling you the way you should practice medicine, and how like this choice, which in many cases is the best choice for the patient, is not the best choice according to this MBA for the machine of whatever organization that they're running. And it's really, really tragic. Like I always say, what's most important is that patients and their docs speak up against this sort of vertical integration, this monopolization of medicine, because, the doctors who just want to practice medicine, our hands are tied and our poor patients suffer because of it. And it's up to us to be as vocal as possible, or the art of medicine will be a thing of the past. So with that, I hope you all have a wonderful, restful weekend, and just ready to crush the week ahead. Let's get it.